Good morning, and I'm Dr. Poonam Rani, and our today's topic of lecture is pregnancy. Sorry, the spelling is mistake here. Now, what is pregnancy and what do you understand by the word pregnancy? See, it is a maternal adaptation. Pregnancy doesn't only mean about the fetus, it is more about the mother. So, maternal adaptation It, it is a maternal adaptation to provide ideal atmosphere for fertilization, nutrition to growing fetus, safe childbirth, and to fulfill nutritional needs of the newborn. So, how pregnancy begins? Pregnancy begins with fertilization. Fertilization of what? Means the union of a sperm and an ovum, which creates a zygote via sexual reproduction. And see what happens: an egg and a sperm fuses to form a zygote. What are the events for fertilization of ovum? How means how an ovum is fertilized. For this fertilization to occur, there are various steps which occur in simultaneously. These steps are occurring and finally fertilization happens. So what are the steps? That transport of ovum from the ovary to the ampulla and transport of spermatozoa from the vagina to the ampulla. Here an environment is created so that both the ova and spermatozoa survive, so that fusion of ovum and sperm takes place. See here, the fertilized egg is formed. Then fertilized egg forms a 2-cell stage, 4-cell stage, 8-cell stage. Then there is a morula stage, then blastula, then early gastrula, and then gastrula. This all you must have studied in embryology lecture classes, isn't it? How there is a cell formation. Fertilization or conception is when the sperm and the egg meet. This occurs in the top one-third part of the fallopian tube. Fusion leads to formation of a zygote and then a blastocyst is formed. Blastocyst travels toward the uterus with the help of the cilia of the fallopian tubes. Smooth muscle activity is influenced by both estrogen and progesterone. How these two hormones influence? Estrogens increase the activity of the smooth muscles while progesterone decreases. Now, how the spermatozoa is transported? Only a few amount of some amount from the many millions of spermatozoa that has been deposited in the vagina is able to reach the fallopian tube. The spermatozoa takes about 30 to 60 minutes to reach the tube from the cervix, pertaining to the speed of about 3 mm per minute through the female genital tract. Ciliary activity and muscular movement of the uterus facilitate the spermatozoa to reach the fallopian tube. Now, this passage from the upper vagina through the cervix is possible only during the fertile period. See, in this portion, only some of the spermatozoa is able to make up to the uterus. From this only some is able to traverse the fallopian tube and only one is able to fertilize the ovum. You can see the fusion of ovum and sperm. How this fusion takes place? Many of the sperms attach to the zona pellucida of the ova. This binding of the zona pellucida happens because of the sperm receptors present in the zona pellucida and a specific egg binding protein or fertilin which is present in the sperm. Binding is followed by the acrosomal reaction, which appears to be triggered by sperm receptors. This reaction is the breakdown of the acrosome, a lysosome-like organelle present in the head of the sperm. Now, when one sperm has fused with the egg cytoplasm, what happens? The membrane potential of the ovum is further reduced. This leads to prevention of the um, fertilization of the ovum with other sperms, so that only one sperm is able to fertilize one ovum. Okay, this is the process how polyspermy is prevented. Now you can see how much time is taken after fertilization uh, for the blastocyst to reach the uterus. After ovulation, fusion of the egg and sperm takes place within 24 hours of ovulation. Then the cleavage starts about 30 hours after fertilization. Morula stage is formed about 3 to 4 days after fertilization. Then blastocyst is formed 5 days after fertilization, and after about 7 days implantation takes place. This should be 7 days after fertilization. Okay. After 7 days of fertilization, actual implantation takes place in the uterus. Now, during pregnancy, there are many changes that takes place, which are responsible for the changes that occur in the pregnancy, subsequent changes in the pregnancy. So, what is the first change to occur? The first change to occur is the endocrinology. Endocrinology of pregnancy means many hormones are secreted at the time of pregnancy, and these hormones define the pregnancy changes. The hormones are human chorionic gonadotropin, human chorionic somatomamotropin, human chorionic thyrotropin, estrogen and progesterone, relaxin, GnRH, and inhibin. These hormones are being discussed in details in your book. So please go through the book and have a look how these hormones are going to make changes in pregnancy. But most important hormone of pregnancy is the HCG, or human chorionic gonadotropin. It is a glycoprotein formed by syncytial trophoblast and syncytial trophoblast of placenta. You must have known that placenta or the fetus has two types of cells, the syncytial trophoblast and cytotrophoblast. Syncytial trophoblasts are the outer layer. These syncytial trophoblasts are multinucleated cell mass which do not have clear-cut cell boundaries, and these are responsible for invasion of the um, fetus or the gestational sac in the endometrium. Okay, after implantation, the gestational sac is um, placed in between the layers of the endometrium, but it doesn't reach the myometrium. Okay, so this HCG is secreted by the syncytiotrophoblast of the placenta immediately after implantation of the fertilized ovum. It is made up of two units, alpha unit and beta subunit. Alpha unit is very similar to the LH hormone, LH, FSH and TSH, and its molecular weight is about 18,000, while the beta subunit has a weight of about 28,000. Since the alpha unit is similar to that of LH hormone, HCG is also having a primarily luteinizing and lutetropic action like that of FSLH, but not like that of FSH. It helps to maintain the corpus luteum, which continue to secrete estrogen and progesterone. As a result, ovulation and menstruation both are prevented, and this HCG can be detected in the maternal serum after about 10 days of ovulation. Now, this HCG, this property of HCG of being secreted in the very early phases of implantation is being utilized for the detection of pregnancy during this early process. You can see that HCG secretion increases in the early phases of pregnancy. It increases and reaches to a maximum or a peak level in about 50 to 60, or you can say 90 days of pregnancy. After which it reduces and reaches a plateau phase, and this plateau is maintained up till the delivery. Okay. While estrogen and progesterone, they start increasing from the early phase, and they keep on increasing, and they reach a peak at about the last in the last trimester of the pregnancy. Pregnancy of in humans is about duration of pregnancy is of about 9 months, and we divide the pregnancy in three trimesters: first trimester, second trimester and third trimester. And there are various physiological changes in the maternal body, very different in all three trimesters, but presently you will study only common changes in the pregnancy. Okay. Now, how do we diagnose pregnancy? Pregnancy is diagnosed by immunological tests and other miscellaneous tests. Immunological tests are Gravindex tests, radioimmunoassay, ELISA is enzyme-linked immunosorbent assay. Miscellaneous tests are hormone withdrawal bleeding test, lateral X-ray pelvimetry, and ultrasonography. Presently, Gravindex test and ultrasonography are the basis for the pregnancy test. Lateral X-ray pelvimetry are usually not done. Okay. Now coming to various physiological changes in pregnancy. Pregnancy is not a pathological condition, it is a physiological condition where the um, mother um, is taking part in forming a small human, or she is playing a role of the incubator in the early human developmental stages. For this, her body undergoes various changes. These changes are in the genital organs. She undergoes weight gain, hematological changes, changes in the cardiovascular system, respiratory system, urinary system, GIT, metabolic changes, endocrine changes, changes in skin, Okay. Now, coming to changes in the genital organs. What are the changes and where do the changes takes place? Most importantly in the uterus, some in the ovaries, fallopian tube, and maximum changes are taking place in the uterus, cervix, and mammary glands. Changes in the uterus are the size of the uterus increases due to hypertrophy and hyperplasia of the myometrium. Weight changes from 30 to 50 grams to about 1000 to 1200 grams. Length of the uterus increases from 7.5 centimeter to about 32 centimeter at term, and thickness of the myometrium increases from 1.25 centimeter to about 5 millimeter. Volume increases from few millimeters to about 5 to 7 liters, and the shape of the uterus, which is piriform to start with, changes to globular. Changes in the ovaries. First 12 to 16 weeks there is a corpus luteum formation. Ovary enlarges and there is a cystic change in the ovary, which this corpus luteum is responsible for the secretion of the progesterone in the first 2 to 3 months. After 12 weeks, the function of the ovary is taken up by the placenta. Now the cervical changes. You can see the picture clearly depicts the normal cervix and the pregnant cervix. What happens? Endocervix is hypertrophy. Cervical gland secretion increases and forms a plug which closes the cervix. Tough cervix become soft. See, this portion is the mucus plug. Changes also occurs in the mammary glands. What happens? There is hyperplasia of ductal and alveolar tissue. The areola gets pigmented. Sebaceous glands become prominent in areola and nipples become larger and pigmented. In the fallopian tube changes its position. It becomes more higher and more vascular. Okay. Now weight gain. In total maternal weight gain is about 10 to 12 kg, of which fetus contribute 3 kg, placenta and amniotic fluid contribute to about 1.5 kg. Uterus and breast enlargement lead to further increase 1.5 kg. Blood volume and interstitial fluid also increases 1.5 kg, and there is about 3 to 4 kg increase in fat deposition. All these things leads to a total increase of about 10 to 12 kg in maternal body weight till the term. Now coming to the hematological changes, there is about increase in 30 to 50% of blood volume. Blood indices decreases means there is a relative hemodilution. Means what is relative hemodilution? Though both the blood volume increases along with the RBC count, both are increasing, but the RBC cell mass is not increases proportionally to the increase in blood volume. So there is a relative hemodilution. Plasma proteins decreases, leukocytes increases, platelet decreases, coagulation factors 7, 8, 9 and 10 increases, leading to a hypercoagulant state. Why there is a hypercoagulant state? This I will be asking again in the next class of parturition. Okay. Why pregnancy is a hypercoagulable state? Again, what happens? There is a suppression of maternal immune system secondary to decreased neutrophil chemotaxis, cell-mediated immunity and natural killer cell activity. So now I have I am giving you two questions. Why the pregnancy is a coagulative state, and why there is suppression of maternal immune system. Okay. Along with, why should there be relative hemodilution? Why? Now, serious changes. What happens? Position of the heart becomes more laterally and upward because of the increasing fetus or the increasing size of the uterus. The position of the heart is pushed more laterally and toward the upward position. There is tachycardia because of the hyperdynamic circulation, and this leads to soft systolic murmur. Cardiac output increases due to increased blood volume. Blood pressure both decreases. Both systolic and diastolic decreases mainly because of vasodilatation. Venous pressure due to gravid uterus rises, causing edema of feet, varicose vein, piles, and peripheral thrombosis. Blood flow increases to the uterus, kidney, and skin. Now there are certain changes in respiratory system also. What are the changes? Diaphragm is elevated. Why? Because of the increasing size of the fetus. Hyperventilation occurs. Progesterone increases sensitivity to CO2. So there is a hyperventilative state. Ventilative function increases means there is increased tidal volume, increase in inspiratory capacity, but decrease reserve volume and decrease functional reserve volume. Gas exchange increases due to increased pulmonary blood flow, and oxygen consumption increases by about 15%. Urinary system changes. There is increased renal blood flow, increased effective renal plasma flow, increased GFR, increased tubular absorptive capacity, increased clearance, increased glycosuria, increased proteinuria, water balance is increased, and increased acid-base balance. Hyperventilation also present, which may lead to respiratory alkalosis. Now there are some changes in GIT also. What are the changes? GIT secretion and motility of the GIT decreases. There is gallbladder function which is increased, liver function, fibrinogen increases but albumin decreases. Morning sickness is present like anorexia, nausea and vomiting. GTT is, what is GTT? Glucose tolerance test will show a diabetic type of test. Gums becomes congested and may bleed on touch. There is relaxation of lower esophageal sphincter leading to regurgitation and heartburn. Now, calorie intake. Calorie intake in pregnancy also increases, and there is increased demand of protein, calcium, iron, folic acid, ascorbic acid. Okay. So for pregnant women, there should be increased protein. This plus shows increased requirement over and above the non-pregnant women. Okay. So if protein requirement for non-pregnant women is about 45 grams per day, then the pregnant lady will need 45 plus 30 gram per day of protein. Calories is requirement is about 300 grams over and above the non-pregnant state. Calcium intake is about 1000 milligram per day. This is wrongly written here. Okay. Here should be 1000 milligram per day. You can see everything has been added, and here also there is an addition of about 1000 milligram per day. So requirement of protein, calories, iron, calcium, folic acid, ascorbic acid, everything is increased for the growing fetus, not for the mother, isn't it? This requirement is for the growing fetus. What are the metabolic changes? BMR of the mother increases, protein metabolism, that is, there is nitrogen retention and positive nitrogen balance, increased blood sugar level leading to glycosuria and decreased hepatic glycogen, increase in cholesterol, triglyceride, and increase in calcium and phosphate retention. Iron metabolism also increases. Endocrine changes, there is increased prolactin, ACTH and TSH but decreased GnRH. Thyroid binding globulin increases, parathyroid, increased active form of vitamin D. Adrenal cortex has increase in all the hormone levels secreted by the adrenal cortex, and in pancreas there is increased insulin secretion. Changes in skin are, there is hyperpigmentation of the skin leading to chloasma or linea alba, and stria gravidarum. What is this? This is the linear scar on the lower abdomen. This you can see the stria gravidarum, and this is the chloasma. You will see a thin hyperpigmented line in this area, and this hyperpigmented line is known as the linea. Okay. There are psychological and musculoskeletal changes also in the pregnancy. What happens? There is craving for particular food, alteration in behavior, emotional and mood changes, and in some cases there can be true psychosis. In the musculoskeletal changes, you can see laxity of the joints, and there may be retention of fluid in the wrist joint, which may lead to carpal tunnel syndrome. Thank you for your kind attention, and in the next class we will be learning about parturition and something else, and you have to answer two questions: why there is a relative hemodilution, and why there is hypercoagulative state in pregnancy. Okay, thank you.